Thank you for joining us today and welcome to the launch of Australia's first national standard on chronic obstructive pulmonary disease. My name is Jonica Newby. I'm a science reporter and broadcaster, and it is my genuine pleasure to be your host for today's event. We're webcasting from the lands of the Gadigal people of the Eora Nation. I'd like to start by acknowledging the traditional custodians of the various lands from which we meet today, and pay my respect to elders past, present and emerging, and to any Aboriginal and Torres Strait Islander people joining us today. COPD is a serious respiratory condition that affects hundreds of thousands of Australians, with significant impacts on their quality of life and overall well-being. It is a leading cause of death and preventable hospitalisation, but also a condition for which there are great opportunities to improve care. The new COPD clinical care standard aims to transform the way care is provided to people living with COPD across Australia. Today, we'll be hearing from experts and people with a lived experience of COPD as we explore what the standard means for clinicians and healthcare services and how it will support improved outcomes for people living with this condition. A large number of experts have been involved in the development of this standard, and we've brought some of those experts together today, and I'm looking forward to hearing from them. But first, it is my pleasure to introduce the Honourable Mark Butler, Minister for Health and Aged Care, for his opening message.
Well, good afternoon, everyone. Before I begin, I want to acknowledge the traditional custodians of the land on which I'm recording this, the Ngunnawal and Ngambri peoples. I pay my respects to their elders past, present, as well as to First Nations people who are participating in the webcast today. Thank you, Professor Anne Duggan, for inviting me to the launch of the Chronic Obstructive Pulmonary Disease Clinical Care Standard. The launch of the COPD Clinical Care Standard is the result of hard work by so many individuals and organisations. We know that COPD is a progressive and debilitating condition which affects an estimated 1 in 13 Australians over the age of 40. It's also one of the leading causes of hospital admissions in Australia. Despite the availability of high-quality clinical guidelines to support the management of COPD, there has been a significant variation in healthcare for this condition in Australia. In fact, the rate of hospitalisation for Aboriginal and Torres Strait Islander peoples with COPD is almost 5 times higher at the rate of other Australians. This suggests that there was more than enough room to improve the delivery of consistent, evidence-based and culturally safe care. This is why the new COPD Clinical Care Standard, developed by the Commission on Safety and Quality in Healthcare that's launched today, is just so important. It will change the lives of so many people for the better. With the standard, we have the opportunity to reduce preventable hospitalisations and to improve overall health outcomes. This all starts with accurate diagnosis to ensure people with COPD receive timely and appropriate treatment to manage their symptoms. It also means people with COPD can take an active role in their own care, knowing how to manage their condition and when to seek help. It puts control of their condition back in their hands, bringing comfort to people with COPD and to their families. I'm really pleased to see that the standard also includes specific considerations for the delivery of culturally safe and equitable care. This reflects a commitment to address the disparities in COPD care for First Nations people and for those living in rural and remote areas. Our government's intent on making sure that access to good health services isn't determined by your postcode. We also recognise the importance of focusing on raising awareness and treatment of chronic conditions such as COPD. We committed nearly $12.5 million to provide patient and clinician support for more than 20 different chronic conditions. This includes providing the Lung Foundation of Australia with $900,000. It means this great organisation can continue to develop and deliver education and training resources for health professionals and consumers, including for COPD. We're also ensuring Australians with COPD are saving on the medicines that they need through our landmark 60-day prescription reforms, saving time and money for Australians with this chronic health condition. I thank the clinicians, researchers, healthcare workers and people with lived experience who provide their expertise and valuable insights to create the COPD clinical care standard. I also thank the Commission for its leadership to bring this enormously important project to fruition. I know that it's the result of a lot of hard work and it will make a real difference to the health and well-being of so many people in our community. Thank you all very much.
Thank you, Minister. I'd now like to introduce Dr. Lee Fong, who is a medical advisor at the Australian Commission on Safety and Quality in Healthcare, a general practitioner and the chair of the topic working group for this project. He'll give us an overview of the clinical care standard and the importance of this work. Welcome, Lee.
Thanks, Jonica. And I would also like to welcome everyone who's joining us from around the country today. I'm really excited that we're releasing this standard today. Let's start with a brief overview of the standard and what the Commission hopes to achieve with it. The development of this standard has been a fantastic experience, largely because it was a concerted effort from a wide variety of very passionate people. If you've been watching this webinar, whether you're an administrator or a clinician, a carer or a patient, I'll bet you're also passionate about doing better with this condition. If we're going to transform COPD care in Australia, we all need to come together in a nationally concerted community and hospital effort. So why did the Commission develop this clinical care standard? This is the first why. These are the words of a person with COPD. Please take a moment to reflect on them. Please consider the individual experience, the individual and awful struggle that sits behind these words. Then multiply that by the lives of an estimated 1 in 13 Australians over the age of 40, with a condition that accounted for half the total disease burden for all respiratory conditions in 2023, and was a direct cause of almost 7,500 deaths and linked to another 11,500 deaths in 2022. Here's a financial cost associated with COPD. At least some of that cost was associated with potentially avoidable hospitalizations for COPD exacerbations. And COPD is a leading cause of potentially preventable hospitalizations. What this tells us is that there's a lot of people with COPD who are experiencing exacerbations, probably getting that can't breathe feeling, for whom that didn't have to happen. It's also estimated that around 50% of people living with COPD don't even know they have it. So that's even more people who aren't getting the treatment they should be getting. Another reason why this standard was developed is the need to address the large differences in COPD care across Australia. In particular, Aboriginal and Torres Strait Islander people have double the prevalence, 5 times the hospitalisation rate and 3 times the mortality rate compared to non-Indigenous Australians. People in rural and remote and low socioeconomic areas across Australia also have higher COPD prevalence and hospital admission rates. Data from the 4th Australian Atlas of Healthcare Variation highlighted up to an 18-fold variation in hospitalisation rates for COPD between local areas. Yep, 18 times the difference. Other reports also show that approximately 50% of antibiotic prescriptions in admitted patients for COPD are inappropriate. Given these issues, we hope the standard will refocus attention on best practice care for the diagnosis and management of COPD across both community and hospital settings. If we can do that, then for people with COPD, we will help reduce at an individual level that awful feeling of being unable to breathe, as well as improve outcomes and overall quality of life. So what's actually in the COPD standard? The standard includes 10 quality statements and a set of related indicators to measure local quality improvement. As with all clinical care standards, this is not a guideline. What it does is highlight key aspects of evidence-based care from existing Australian clinical guidelines, including COPDX and therapeutic guidelines. The idea of the standard is if we can get these 10 aspects right, we can do a lot to improve the quality of COPD care. I'll now give you a quick overview of the 10 quality statements following the patient journey from diagnosis. The statements fall into 3 broad groups of priority areas. Firstly, there are 6 quality statements in the standard focusing on managing COPD to prevent exacerbations and hospitalizations. Diagnosis and comprehensive assessment is where it all begins. We need to use spirometry to ensure an accurate diagnosis of COPD, and we need to do comprehensive assessments so we can be confident we are holistically managing people with COPD. Patient education and self-management are also critical. This means empowering patients with knowledge and strategies to manage and live well with their symptoms. Living well includes key preventive interventions such as vaccination, and for those who smoke, quitting tobacco smoking. Pulmonary rehabilitation is another intervention strongly supported by evidence. We need to find our ways to get patients with COPD into pulmonary rehab programs and help them maintain those benefits after they finish. And of course, having access to the right medications for managing stable COPD also plays an important role. Maximising the benefit of medication involves both a stepwise approach to treatment and, very importantly, checking inhaler technique. When it comes to managing COPD exacerbations, the standard highlights 2 areas which are of vital importance, as well as appropriate pharmacological management. This includes oxygen and ventilatory support. And to complete the cycle, we need to have safe and smooth transitions of care and coordination back to the community after exacerbations. While the last statement in the standard addresses palliative care, I'd like to emphasise that palliation is not just about end-of-life care, but also about improving symptoms as much as possible and as early as possible. As a very important final note, advice about culturally safe and equitable care has been incorporated throughout the standard. So I hope this quick overview gives you a sense of what is in the standard and why it's so important. Please check out the Commission's website to find out more. Let's improve outcomes and overall quality of life for people with COPD. Let's reduce that awful feeling of being unable to breathe. Thank you.
Thank you, Lee, for that introduction to the standard. Let me now introduce the rest of our expert panel. Professor Jennifer Allison is a Professor of Respiratory Physiotherapy at the University of Sydney and led the development of the Australian Pulmonary Rehabilitation Guidelines. Dr. Kerry Hancock is a general practitioner who chairs respiratory-focused special interest groups with the Royal Australian College of General Practitioners and Lung Foundation Australia. Ms. Mary Roberts is a clinical nurse consultant at Westmead Hospital with extensive experience in respiratory medicine and is a clinical fellow at the University of Technology, Sydney. And Associate Professor Natasha Smallwood is a consultant respiratory physician at the Alfred Hospital and President-elect of the Thoracic Society of Australia and New Zealand. Welcome and thank you all for joining us. Now, to set the stage for our discussion, I'd first like to share John's story about his experience with COPD and the profound impact it's had on his life.
I was diagnosed in 2005 with COPD. Prior to that, I hardly went to a doctor. I ended up with a continuous cough. I couldn't breathe. I couldn't walk, and the family finally got me to go. He sent me directly to a specialist, lung specialist, I then found out that I had COPD and gave me 18 months to live. I went back to the GP 2 months later, and sitting around in the reception area, I found a brochure that had COPD on it. And then I realised that's what I had. I just assumed COPD was another flu, and I didn't worry about it. It was a big shock once we found out what it was. And it more or less changed your whole lifestyle. But I had to instantly retire from the Commonwealth Government. And we didn't do much travelling, but we did a little bit of travelling. And then it slowed down because of the problem. And today, I'll be lucky to go out to the letterbox and back without losing my breath. And it really holds you back. Your whole life has changed where you can't do much. And it's, you know, you do see other people running around and you wish you could do the same, but unfortunately, that's the problem with COPD.
John told us about having a COPD action plan.
Well, when you're first diagnosed with COPD, you're supposed to sit down with your specialist or clinician, and they'll go right through everything you're supposed to do day to day, all your medications, exercises, everything else, and that gets put onto the action plan. And then if you feel unwell, it then explains what you've got to do to try to release that. If that doesn't help over a quarter an hour, they recommend you ring your GP. If you can't get onto your GP, they recommend you go to the emergency section at the hospital. But it is a good thing, so my recommendation is get a copy of it and carry it with you no matter where you go.
We asked John about his thoughts on his COPD medicines.
Well, most people on COPD are given inhalers to control or keep their COPD under control. But now they're saying that about 80% of people using these do not use them properly. And they suggest that you either go to your clinicians and get them to check how you do it and correct it, or go to the pharmacy. And they're happy to even help you do it correctly.
Well, that was a pretty powerful account of just how impactful a COPD diagnosis can be, and it was actually quite moving. But it also highlighted for me what can go wrong. I mean, John left his specialist not knowing what COPD was and having 18 months to live. So we'll come to communication later, I think, but let's start with diagnosis. Natasha, the standard focuses on the use of spirometry to confirm a diagnosis of COPD. Why is that so important, and what can happen if it isn't done?
So spirometry is absolutely essential. It's the gold standard test that we utilise to identify if someone has COPD. So someone can't really have the diagnosis unless we've done the testing. The other aspect is spirometry is actually really important in terms of us determining the severity of the airflow limitation. And so understanding that helps me to understand as a physician the severity of their illness and potentially their prognosis, as well as the treatments that we need to deliver.
Well, unfortunately, the statistics tell us that spirometry use has dropped off in recent years, particularly at the GP level. Kerry, to try and turn that around, what advice would you give GPs about performing spirometry now? What are some of their options?
Okay, so depending on where a GP is geographically, it can be quite challenging accessing spirometry. Now, some GPs may have trained staff in their practice that can do the spirometry for them, but it needs to be well performed and meet quality standards. I would suggest that if GPs don't have on-site spirometry, then certainly to check the health pathways put up by their PHN and see if there's some information on that will give them some advice about where to access spirometry, because it might be at their local public hospital, it might be at some specialist rooms, it might be that there is a mobile service that they can access. But they could also consider training their own staff so that they do have it on site. But even when that happens, they often do have to use other services as well. So I think this is a real challenge for us in Australia at the moment, is access. And as Natasha said, getting that diagnosis by spirometry is absolutely critical. And the GP-based spirometry has certainly fallen off through the pandemic and has not come up again. So I think we need to activate all those other services that can offer spirometry to GPs, and let us be able to get very easily accessible spirometry so that we can make these correct diagnoses.
A bit of a call to action there.
It is, absolutely.
So Mary, is this something that nurses could help more with?
I think, yeah, definitely. I think that we need to utilise our practice nurses, ensure that they're properly trained and that they get accredited so that they can do spirometry. And then once the spirometry has been done, they can then give it to the GP to actually interpret. So I think that that's a good way of accessing spirometry.
Now, Lee, the standard also highlights the importance of every patient getting a comprehensive assessment. Why does that matter, and what should that involve?
So I like to think it matters in the same way that if you had a car, you would get it serviced. So if you take your car in for a major service, you're doing it because you want to make sure that it's not going to break down and it's going to run as well as it possibly can. So same thing. If you get your COPD comprehensive assessment, you're looking for the same things. We want to reduce exacerbations. We want to reduce the severity of exacerbations. So what does it involve? Well, again, I'll go back to, say, a logbook service. You've got a checklist. There's a few things you'd run through for a car service. For a COPD comprehensive assessment, you're looking also at a sort of a checklist as well. So it'll have things like severity, frequency of exacerbations, looking at what are the current symptoms, how is that impacting on current life. There's some validated questionnaires that would help take people through that. What medications are you on? How are they working? Do they need to be stepped up? Do they need to be stepped down? Are you smoking? What are we going to do about that? So there's a range of things that are involved. It's a comprehensive check. It's not just one thing. So again, with the car thing, it's not just kicking the tyres and changing the oil. It's doing a range of things in a comprehensive way. So you get that holistic understanding of and management approach.
I guess you mentioned smoking as well. I mean, we know that around 30% of people who have COPD have never smoked. But for those who are still currently smoking, the evidence is that is the most effective thing they can do for their outcomes, is to quit and be supported by their GPs and others to do so. Now, John also talked about some of the strategies he uses to manage his COPD. His hot tip was carry your action plan with him. I believe his is on his phone. Jenny, can you tell me why encouraging patient self-management is such a key focus of the standard, and again, what that might encompass?
Yeah, sure. I think it is a key part of management, and it's largely because COPD is a chronic condition. So being a chronic condition, patients need to understand themselves and know what they can do. They're living with their condition 24/7, and they need to know what their symptoms are, if they're getting worse or not so bad, and what to do about those. So the key management strategies or self-management strategies are, first of all, educating the patient about what COPD is and what's changed in their lungs that's different from other people their same age if they have COPD, and also how to manage it. So John talked about the action plan. Well, that was really important, and I think we've spoken about that. but there are other things to do. So symptoms are really important. There's symptoms of breathlessness and fatigue are things that stop people from doing being involved in their daily life. So self-management is teaching people how to manage those symptoms, like managing breathlessness, what sorts of tools that they can use or strategies. Sometimes people find a handheld fan works well. Sometimes learning how to position themselves to recover from times when they're breathless. So managing breathlessness, learning how to be physically active, because we know that that's important for the long term. People who are more physically active usually do better. So around physical activity, around managing anxiety and stress, because sometimes that can make people very breathless, and things like healthy eating. Doesn't necessarily mean overweight or underweight, but eating healthily, as we all know, in general health is really important for health. So those sorts of things are the things that we talk about when we talk about self-management strategies. And the better patients with COPD can take on those strategies, the better, like your car analogy, Lee, the better the car will run. And they'll know when that little tick in the engine means something to them, like they're deteriorating, and then you'd go and do something along your action plan lines.
I guess the point here is, of course, to try and prevent those unnecessary hospitalisations.
Mm-hmm. Yes, and early intervention, especially when people feel like they're deteriorating, can make a big difference to preventing those hospitalisations.
I want to switch quickly to you, Mary. And this is about messaging. How important is it to give a positive and empowering message to patients with COPD, unlike perhaps what John received early on?
Look, it is really vitally important. I think there's always been this pessimistic thought about COPD, there's nothing we can do for it. When that is so wrong, because there are so many things that patients themselves can do, but also healthcare professionals. So we should stop being pessimistic and start really having the optimism that self-management, using medications properly, remaining active, that there are lots of things patients can do to live the best life.
And Lee, I just want to go a little bit more into action plans, because this is, again, something that the standard emphasises that everybody should have an action plan developed with their clinician. What exactly might that encompass? And I guess also it could be tempting for a very busy GP to just go, here's my standard action plan form.
Yeah. Well, this comes back a lot to self-management.
Yeah.
And I think a lot of it's about empowering patients to be able to say, let's use the car analogy again. If you've run into a traffic jam, then do you panic and then you take the first turn to the left and just hope it goes well, or do you pause for a minute? So maybe think about an action plan like the soothing voice of your GPS navigation. So when you
do love a metaphor, don't you?
So if you hit that traffic jam, your action plan is like the GPS, just gently rerouting you.
Okay, and from the GP's point of view, to develop that action plan, I presume it's something quite individual to each person.
Yes, it is. And there are standard forms, as you were, I think, indicating. But it's about individualising that for the patient.
And then they have more ownership, of course, of it, I assume.
Absolutely.
Yeah. And just to go a bit more into something you raised, which is about the management of difficult symptoms. You mentioned breathlessness, for example. Natasha, do you have any key advice for clinicians when discussing strategies for managing difficult symptoms, such as breathlessness?
I think the key thing is actually to remember to ask about it. So often when we see patients, if you don't actually watch someone walk into the room, you can completely miss the fact that they are breathless, because by the time they sit down, they're often fine. So it's often considered an invisible symptom. So making sure we're very proactive about asking symptoms. The symptoms are why the patients come and see us, but we often forget that and try and treat the disease. So trying to take that patient-focused, individualised approach so that we ask what they can and can't do is really critical if we're going to respond to their needs.
Mary, do you have anything to add to that?
Yeah, definitely. And I think the key question I always ask my patients is not, are you breathless? Because they'll often avoid activities to avoid breathlessness. The key question is, what have you stopped doing because of your breathlessness? And then that really opens up the conversation, and then you can find out what they've stopped doing, and then you can empower them and giving them tips and tricks on how to manage that symptom so they can get back doing the things that they've stopped doing.
Yeah, and I was interested that you mentioned, and I'd heard about this, that this is something you sometimes suggest, Mary, that even just using a fan sometimes can be enough to calm people down and avoid medications.
Yeah, there's some great medical evidence that the use of cold air on the bottom half of the face can actually reduce the symptom of breathlessness and speed recovery.
Yeah, wow, that's great to know. And that brings us to medications, because they are, of course, part of care of people living with COPD, but it is an area where there's a lot of variation in prescribing. Natasha, the standard recommends clinicians should adopt a stepwise approach to pharmacological management. Why is that?
So I think the first thing to say is that COPD is not asthma. So the approach we take is very different. So the final step in managing COPD is to add an inhaled corticosteroid, whereas in asthma, we take that step much earlier. So I just need to stress they are completely different conditions. So when we talk about a stepwise approach in COPD, we're trying to be rational about the medications we use, because medications have side effects, and we're always trying to manage harm versus benefit. So when we talk about a stepwise approach, what we're talking about is initially using the minimal medication the patient needs. So for example, at the start, they might just use a short-acting beta agonist, and then we step them up to use long-acting medications. We start with 1, then we bring in 2. And then if we need to, we consider the use as the final step of inhaled corticosteroids. And really, the people we're thinking about that for are people who are having frequent exacerbations, which was something that Lee touched on before. And so by frequent exacerbations, what we mean is somebody who's had 2 community exacerbations or has had 1 severe exacerbation, bringing them into hospital. So they're a very set group. The other group we might consider using triple therapy in are people who remain highly symptomatic despite having dual therapy. But it is absolutely critical that we remember it is the final step, because there are harms associated with inhaled corticosteroids, and we need to remember that.
Is this an area that to date has been less than perfect, the prescription of inhaled corticosteroids for COPD?
Absolutely. So we often see that there's overuse of inhaled corticosteroids in people who don't need them, but we also see there's underuse of prescriptions for people with COPD. And a lot of that relates to inadequate diagnosis and inadequate assessment of the severity of the underlying illness.
Back to spirometry.
Absolutely.
And John also mentioned inhalers. Now, I was startled to learn that I think the statistic I was told was 90% of people don't use their inhalers correctly. I was told one woman was spraying it in the air and then trying to catch the medication like this. Kerry, does that ring true for you? And how important is it to check inhaler technique regularly?
It's very important. We've seen some really weird stuff over the decades, you know, people spraying it around and as you said, trying to sort of catch it. But if one thing I could emphasise is that as clinicians, we should all know how to check a patient's inhaler technique ourselves, okay? Because we know that many clinicians are actually not good at doing that themselves. And then every time we have an opportunity to actually check our patient's inhaler technique. And look, if we don't feel confident doing that, then there's plenty of other people who can, like the community pharmacist or the specialist pharmacist through a home medicines review, respiratory nurses, train our practice nurses in it as well. The Lung Foundation, you know, runs courses for that. So lots of opportunity. If the GP themselves don't feel confident, then get someone else to do it. But as long as the patient gets it done and gets it checked on a regular basis.
Yeah, well, I guess given those statistics, you'd certainly want to check inhaler technique before you escalate to, say, medications or other sorts of interventions.
And there's so many different types of inhalers, and we forget, if we've changed the prescription, then it might be a different inhaler than what they had last time, or the patient might be using 2 different types of inhaler as well, and that can create a bit of confusion for the patient. They don't know whether to breathe in deep and fast or slow and not so fast, so it's absolutely critical, otherwise you're wasting a lot of medication unnecessarily.
Okay, well, let's hear more from John about his experiences of living with and managing his COPD. John recounted his experience of a COPD exacerbation.
It happens where your breathlessness becomes worse. You end up with a fever. You get tightness in the chest. You start losing memory, trying to remember things. It's a very nasty thing. But because you're just trying to get your breath, nothing matters. There's another thing called panic attacks, which is what I get a lot. And it just hits you out of the blue. You'd be outside somewhere. And it's very similar to a flare-up, where you just can't get your breath at all. And you just lose everything by trying to get your breath back.
We asked John about his thoughts on pulmonary rehabilitation.
Pulmonary rehab, it's a terrific project. It's an 8-week program. And what they do, they assess you and work out what exercises suit your condition. You do your exercises. And then in the afternoon, they have education. And that way, it's one of them is living with COPD. You have a dietitian come in, talk about your food and what you should eat now. You have others, mental health, and all these people come through, and it's a very good system. I hope that the COPD clinical care standards will come in and help with these people to go along, because I think if they do this, it would reduce their, it'd increase their life expectancy, but reduce the readmissions to the hospital. The only problem with it, after 8 weeks, you're then told to go home, keep taking your medications, do your exercises, and include myself when I left. What do you do? You can't go to a gym because they'll kill you. So we then went out and got a couple of grants through our lung support group. And with that money, we've got a physio qualified to come in and give us the proper exercises that these people needed.
John told us about his work as president of a lung support group.
The lung support group's been going since February 1999, and for the last 7 years I've been the president. What we do there is that we have bus trips, lunches, professional speakers come in, and most of all, you get to meet other people with the same condition, so you're not alone, and they get you out of your house and into a group. Yeah, and I think anyone with COPD should join a group, local group near them. But I think the main thing is friendship. Don't just cut yourself off at home, but try to join in with other people who have got the same condition.
John described the support he receives from the clinicians involved in his care.
I'm very lucky. I've got the wife who's very good there. I've got a doctor who rings me every week. I've got a COPD nurse at the hospital, and if I have any trouble, I ring her and she'll come straight back to me. If it's a medical problem, she'll ask what it is, and then she'll decide if it's a doctor, a specialist or hospital job. And I think new people with COPD today need that contact. They need to have a GP, a specialist that they can talk to, possibly a nurse at the hospital that they can contact and become a contact person.
John spoke about the importance of the COPD clinical care standard.
And I think that coming back with the COPD clinical standards, these people get the proper care that they deserve and need. And I think it's a very, very important thing. And hopefully to save these people, expand their life, and also it should reduce readmissions to hospitals if these clinical standards are taken into account.
Well, there are a lot of great examples there, weren't there, of what really good COPD care and support looks like. It was quite heartwarming, actually. But John also gave a big rap for pulmonary rehabilitation, and you're the guru of this, Jenny. Can you tell me about pulmonary rehabilitation, because the standard has a big emphasis on it? What does it involve, and what are its benefits for people with COPD?
Yeah, thanks, Jonica. Look, just like John said, it's usually a 6 to 8 week program where people go twice a week for supervised exercise training, education and self-management strategies. But what pulmonary rehab, the evidence for pulmonary rehab is very strong. So in other words, many randomised controlled trials and analyses have shown that pulmonary rehab improves exercise capacity, health-related quality of life, reduces anxiety and depression, and can help to prevent hospital admissions or readmissions after an exacerbation. But why it's so important is, I was thinking when John was talking, as a GP, if you refer somebody to pulmonary rehab or even as a specialist, what doesn't happen is you don't always have time to spend that amount of time with a patient to help them understand their condition. And so when somebody comes to pulmonary rehabilitation, they come twice a week. They see health professionals, like John said, around the education side. But also the important thing is that a lot of people with COPD who are breathless are really frightened about coming to rehabilitation. They think they're going to be put in a gymnasium and
gyms will kill you.
Yeah, gyms will kill you, exactly. So the really important thing is that the professionals who are referring people to rehabilitation really help the patient understand what it is. And what it is, as John said, is we provide an assessment initially, and part of that assessment is taking a good clinical history so we know what things people can and can't do, what might be their comorbidities and what might be their musculoskeletal problems for exercise. And also we do a exercise assessment, and we base what the program is on that individual's response to exercise. And so people shouldn't feel frightened to come because they're in the hands of experts who know how to do this. We progress the exercise over time so that people, when they finish the program, really do genuinely, and as John said, feel so much better about life. I mean, what we're trying to do, going back to what you were saying, Mary, is we want people to live as well as possible with their condition, live their lives to the max, optimistic, and pulmonary rehab can do that for people. So it's, I think it is one of the key cornerstones of COPD management from that point of view.
Well, Mary, you started some awareness and education programs for clinicians about pulmonary rehabilitation. What led you to do that, and how does it help?
Yeah, I think one of the problems that I came across were patients were saying, my GP said I don't need to go to pulmonary rehab because it makes me breathless. And as Jenny and I would say, if you're breathless, you need pulmonary rehab. And once again, reassuring the patient that it will be individually prescribed for them. So if they can walk 3 metres, we're going to train them to walk 6 and 10 metres. If someone can walk 500 metres, well, we'll be encouraging them to walk 800 and a kilometre. So it is very individually prescribed. And I think that we have to, there's only about 5% of patients that would benefit pulmonary rehab actually get referred. So I think that we really have to get out there and educate everyone about pulmonary rehab. And if you're not sure where you can refer, it's going onto the Lung Foundation Australia's website. There is a great search tool where you put in your postcode and it will say where the nearest pulmonary rehab program is. If you are in an unfortunate position where there is no program, it's then reaching out to some healthcare professionals to see if there's some tele-rehab or if there's other exercise programs that may help access the similar services.
Well, I wanted to pick up on that because the reality is that in some areas, the demand for pulmonary rehabilitation outstrips the supply, and the standard actually encourages people to search out alternatives. So can you explore a little bit more, both of you, of what those alternatives are? And I guess, again, is this something where nurses could be doing more, Mary?
Yeah, so I think that contacting the Australian Lung Foundation and asking what services they've got. And we also run an Australian network of pulmonary rehab clinicians. So linking in with one of them so that you can actually get mentored and trained the healthcare professionals in your area. And sometimes there may not be physiotherapists available, but there's exercise physiologists and nurses that are trained in providing pulmonary rehab are other alternatives. But Jenny's been working with some clinicians to provide tele-rehab and other methods. Jen, do you want to talk about that?
Yes, well, I think the evidence is growing. So in other words, we originally said, gold standard pulmonary rehab is centre-based, like John was going to, where you come twice a week. But there's beginning to be very strong evidence in our guidelines, we've talked about that tele-rehabilitation can be equally effective. So when we say tele-rehabilitation, it can take a number of forms. So one of the ones that are probably closest to a centre-based program is where there's video conferencing and the person is being viewed all the time by the physiotherapist to do the exercise during the exercise part. But other modes of tele-rehabilitation, like having a centre-based, all of them should have a centre-based assessment first. That's probably key. But then, and the program designed, but then people can do it in their homes and be called once a week. So a physiotherapist might go to their home, set up the program for them after they've been assessed, and then continue to monitor them as they go forward. And there are other modes like some apps that are being developed where a centre-based assessment and then you do the rehabilitation through the app with, again, a clinician contacting them every week. And the other part of that is very important, is saying that pulmonary rehab is not only exercise training, but the education and self-management. So that has to be incorporated. And that's where the Lung Foundation sometimes is very pivotal in terms of the education that they provide online as well for patients who want to follow their online education programs.
And can I pick up with you to this question of culturally safe care? Because I believe this is an area you've been looking at too, particularly for Aboriginal and Torres Strait Islander people. If there's just one thing you want to say about that, what would it be? What do people need to bear in mind?
Yes, well, I think there are two things. Going back to Lee's statistics at the beginning, what the big gap is, 5 times the hospitalisation rate for Aboriginal and Torres Strait Islander people compared to non-Indigenous Australians for hospitalisations for COPD. And what we've found in working with Aboriginal community-controlled health services is that many Aboriginal people, number one, are not aware of that there's anything to do for their COPD. They think it's like a death sentence, that they have relatives who've died and there's nothing you can do. We know that's not the case. So educating community, but also the biggest problem, I think, is that Aboriginal people and Torres Strait Islander people aren't very keen often to go to hospital because of their previous experiences with racism, etc. And therefore, providing pulmonary rehabilitation in a culturally safe environment, and in most instances that would be through Aboriginal community-controlled health services who could provide that rehabilitation in their local area with local Aboriginal people being involved in their care. And I think that's probably the critical thing to ensure that those programs could be more widely available. They're very limited at the moment because Aboriginal community-controlled health services are like large GP practices, but they do need support to be able to provide that culturally safe environment for rehab.
Another call to arms. Yeah. Okay. So for our final topic, we're going to discuss managing exacerbations. Now, John gave us a vivid account of his experience of flare-ups, and this can be a situation where something needs to be done and urgently, and it often leads to hospital. Natasha, a serious exacerbation, this is a point where drugs are often necessary. even life-saving, but you'd still like clinicians to be mindful of their use.
Absolutely. I guess the first thing to say is an exacerbation or a flare-up is about a change in symptoms that isn't just day-to-day variation. So it's a change in symptoms over a few days that requires the patient to step up treatment. And often the patient, if they've been adequately educated, is going to start self-initiating treatment, so they'll be using their reliever medication more. The step after that is to consider adding an oral corticosteroid, but just as a relatively short course. So we really recommend no more than 5 days, because if it's used for longer, then again, there are side effects for the patients. And if it's used for longer, it then actually also has to be weaned. So again, we're exposing people to things that they don't need. In addition to using oral steroids, in some people, antibiotics are required. And this is the whole issue. It's about antimicrobial stewardship. So, for example, if the person's got symptoms of increased sputum purulence, increased sputum volume, or they've got a temperature, those are people who are having symptoms that may be consistent with infection and in whom we want to give an antibiotic to. But again, the thing that we're trying to encourage is that it is antimicrobial stewardship. So we use the antibiotic that is most appropriate. So they don't need intravenous antibiotics, and potentially if they come to hospital, yes, but largely they don't need intravenous antibiotics. And we're using the simplest antibiotics. So for example, in the standard, we talk about using amoxil or doxycycline, not using broad spectrum antibiotics, because we will drive community resistance. So this is why we're really trying to have stewardship and educated decision making about how we manage exacerbations.
And if you do end up with a big exacerbation, hospitalisation, would you see this as both a red flag for that patient but also an opportunity?
Absolutely. So, I mean, it's a huge red flag if someone comes to hospital. In many ways, it's actually a failure on our part that we've actually got to that stage. So it's a huge call to arms of what can we do? And it's where comprehensive assessment comes back in. Have they actually had their spirometry? Have they had a comprehensive assessment? What do we need to do to optimise the management for that patient? And actually, how can we support them in the community and communicate with their general practitioner and community team to better manage that patient?
Well, given all that, Mary, for people who have been hospitalised, obviously getting that smooth transition back into community self-management is crucial. What sorts of things should clinicians consider for getting a good transition back into the community?
I think once somebody has been admitted for an exacerbation of COPD, they definitely need a referral to pulmonary rehab, even if they've done it previously. I think that there's great evidence to say that people need to be referred to pulmonary rehab. And as Jennifer was saying, that in pulmonary rehab, we can actually go through some of those self-management strategies again, teaching patients how to use their COPD action plan, checking on their smoking status, checking on how they're using their inhalers, getting them to recognise their symptom changes and not ignoring them. But also, I think it's really important that that transition back to the community, that we communicate to the GP and let them know what's happened, what's been discussed. Have we discussed advanced care planning? Have we referred them to pulmonary rehab? Have we changed their medication? So I think there has to be really strong communication, that the patient doesn't exist in a silo. They have contact to a lot of different healthcare professionals, and I think it's up to all of us to communicate the ongoing care of that patient.
Sure, and obviously the GP is still a critical point of contact.
Absolutely.
Lee, is there anything you'd like to add to what Mary
Well, I
just
think
said?
it comes back to that of us all working as a team.
Yeah.
It's about working not just, for example, in a hospital setting, or not just working in a community setting, but thinking that we're all coming together because we share a common patient, and that when the patient is in another setting, they don't suddenly become somebody else's patient. We hold that. And again, I think if we're focused on simply, this is our patient across the system, we're trying to reduce the symptoms that they're having, that experience of feeling like you can't breathe, then with the aid of some things like the clinical care standard, hopefully we can get our patients to a better place.
Well, thank you. That's a brilliant spot to end our fascinating discussion. We are now going to hear from Professor Christine Kilpatrick, Chair of the Board of the Australian Commission on Safety and Quality in Healthcare, who will officially launch the standard.
As Chair of the Australian Commission on Safety and Quality in Healthcare, I'd like to thank you all for joining us today. As we have heard, COPD is a serious and significant problem in Australia and is a leading cause of potentially avoidable hospital admissions. Timely, evidence-based management of COPD is key to improving outcomes and reducing hospitalisations. The journey of patients with COPD includes primary care as well as acute hospital services. To improve care for people with COPD, we need to make a concerted effort across the health system. This new National Clinical Care Standard is designed to lead those improvements in care. I encourage you all to use the standard and its resources wherever you are in Australia. I'd like to thank all of the clinicians and consumers who have contributed to the development of this important standard, especially our panel members and consumer representatives. With this, I am very pleased to officially launch the Chronic Obstructive Pulmonary Diseases Clinical Care Standard and to recommend its adoption by clinicians and healthcare services across Australia.
Thank you, Professor Kilpatrick. I'd also like to thank our panellists, also John and you, our audience, for joining us today. I hope this work will be the start of some important changes in the care for people living with COPD. You can find more information about the new COPD Clinical Care Standard on the Commission's website, including resources for consumers, clinicians and healthcare services. You will also find a recording of this event, so please tell your colleagues about this webcast and share the resources widely. My name is Jonica Newby and I want to thank you so much for joining us. Goodbye.